I'm Danielle Horton. I'm a child abuse pediatrician at Children's Mercy in Kansas City. And today I'll be talking about bruising with a specific focus on the 10-4 FACESp clinical decision rule. So Missy, the case was great for some examples of some pattern bruising and concerning locations, all of which we'll talk about today. So today we'll talk about bruising characteristics that can help discriminate abusive from accidental trauma, and we'll discuss the literature around this bruising clinical decision rule known as 10-4 FACESp. Some of you might be familiar with this already. If you're not, that's okay. We'll go into details about it today and talk about a recently published study regarding this and how it can be applied to practice. So as we all are aware, bruising is the most common manifestation of child physical abuse, and probably one of the most common reasons that most of us are asked to evaluate a child when there's concern of abusive trauma. Bruises are often considered minor, but minor injuries may be the only physical clue that abuse is happening and often precede more severe abuse. So it's critical that we are able to recognize which minor injuries are concerning. We also know, though, that bruises are common accidental injuries. So how do we know when we need to be concerned and which kids need further evaluation? And sometimes certainly this can be challenging. There are several studies in the medical literature that have addressed these questions and demonstrate three factors that are important to consider when you're evaluating a child with bruising. Age and developmental status of the child is one of these. The bar figure that I've shown here is taken from Naomi Sugar's study in 1999 on bruising in infants and young children, and demonstrates the importance of considering age and developmental stage. So along the x-axis, she is showing child age in months from youngest to oldest, and the y-axis shows the percent of kids with bruising. And what they demonstrated in their study is that bruising was rare in kids who were under 6 months of age, or that pre-mobile age group, and then bruises increase with increasing independent mobility. Findings from more recent studies have also been consistent with this and added to our knowledge. One example is Kemp and colleagues studied patterns of bruising in young children. They had excluded abuse, and they had actually recruited kids from well child clinics and in the community and had parents document bruising on body diagrams over a period of weeks. And so this figure here on the far side is from their study. And those child diagrams show the pre-mobile, early mobile, and walking kids with lighter shading indicating a lower frequency of bruising and darker shading indicating higher frequency of bruising. So their study, you can see again, showed similar to the Sugar study that bruising in that pre-mobile age group was rare and increased as children began to have more mobility. It also demonstrated that bruising location matters. So bruises weren't necessarily just popping up anywhere, but most of the bruising in kids that became more mobile was isolated or most prominent over areas below the knees, and your bony prominences like forehead and chin. Last, we know that bruises that are patterned, such as imprints of objects or clustered areas of bruising, are rare from accidental trauma and concerning for abuse. And we'll talk a little bit more about that as we review a couple more studies in this lecture. So today, I'm going to review the findings from two papers by Mary Clyde Pierce and collaborators that identify features of bruising that can be used to discriminate abuse from non-abusive injuries. We'll discuss the bruising clinical decision rule that's known as 10-4 FACESp that was developed from these studies and how to apply it in practice to improve our detection of abusive injuries. So first, we'll consider this study that was published in 2010. The study authors designed a pilot study to identify bruising characteristics that could discriminate physical abuse from accidental trauma. So this was a retrospective case control study, and they looked at kids aged 0 to 48 months that were admitted to a pediatric ICU for trauma. They divided those into groups, physical abuse and accidental trauma. So there were 42 victims of physical abusive trauma, and then there were 53 control subjects who had sustained accidental trauma. I think about half of those were motor vehicle accidents and the other half were non-motor vehicle accidents. All the kids had thoroughly documented skin exams per their standard PICU protocol. And so they looked through the charts and compared bruising characteristics that were documented for these two groups, physical abuse and non-physical abuse or accidental trauma. Specifically, they were looking at characteristics of total number of bruising, the body region where bruises were located, and the kid's age. And they found some significant findings. So they found that kids with abuse had a total bruise count that was significantly higher than those who had sustained accidental trauma. They also found significant differences in body regions where bruises were documented. So in this study, bruising to the ears, the neck, hands, chest, and buttocks were perfectly predictive of abuse, meaning that in their population, no patient with accidental trauma had bruising in those areas. They were only seen in their abuse patients. Again, this is just in their small population. They also found that back and abdominal regions were statistically significant for discriminating abuse. And they also noted that bruising to the genital area and the hip was only seen in patients with abusive trauma, but this was a really small number and too small for them to determine if it was statistically significant. So in table 3, which is from their study that I've included here, this shows bruising in what they defined as the 10 aggregate region, with 10 standing for torso, ear, and neck. And they're comparing the number of bruises in this 10 body regions to the abuse versus the accidental injuries. It's important to note that torso, for torso, they actually included chest, abdomen, back, buttocks, genital area, and hip. And then you've got ear and neck. And so you can see the total number of bruises in these areas for abused kids was quite a bit higher, whereas the kids with accidental trauma either had none in these areas or very few. So they took this information and developed a proposed clinical decision rule. So clinical decision rule is a point of care tool that can help improve decision-making accuracy. And why this is important for abuse is that this type of tool might prevent further abuse through improved recognition of bruises that are concerning for abuse. We all know there's times that sometimes concerning bruises are overlooked, or it can be difficult to determine if they're concerning for abuse or accidents. So they knew that bruising, from their study, bruising in this torso, ear, and neck region was significantly associated with abuse. So they used this body region in creating their tool. They also found that age mattered. So they found that if they used an age cutoff of bruising anywhere in an infant who was under 4 months of age, they correctly captured an additional 7 patients who had abusive trauma that would have been missed if they had screened them only using the body region bruising, the 10 rule. So they created this rule that they named 10-4, and then they applied this clinical decision rule to their population and found that using this tool, it correctly classified 32 of their 33 abuse victims. So that's pretty good. And so they proposed that 10-4 could be applied when a child under 4 years of age was seen with bruising to help improve recognition and decision-making around abuse, such that any child who had a bruise identified in the 10 region or a child under 4 months of age with bruising anywhere should raise concern for abuse and need further evaluation. And this is a great proposed tool that theoretically would be easy to use in different clinical environments, but there were some limitations. This study population was a small group, and it was just kids admitted to a pediatric ICU. So it's hard to know if conclusions could be drawn regarding bruises in less severely injured children and whether it'd be generalizable to other settings. It was also retrospective, so they were reliant on the documentation in the chart and lacked some detailed information about bruising to specific face areas and pattern bruising. So they decided that they needed to do some prospective testing and validation in other settings. So that brings us to the recently published study by the same author group. It came out in April of this year, 2021, where they refined and validated the bruising clinical decision rule, as well as addressed some of those limitations from their prior study. So what they did for this one is that is a prospective study, and they enrolled over 2,000 children under the age of 4 who were seen with bruising across 5 different emergency departments. So kids, the reason for their visits at the ER could have been for medical evaluations, trauma, or specifically for child abuse evaluation. A child with at least 1 bruise was eligible to be enrolled in the study. And they did exclude kids who had known motor vehicle accident injuries, known bleeding disorders, or severe skin disorders. Because this was prospective, the research team was able to collect detailed documentation about bruising in the moment, ensuring consistency among the level of detail of data collected for both the abused and non-abused patients. So they divided the study population into kids who they determined to be definitely abused and kids who were not abused. And they compared characteristics of bruises that were documented in the abused versus non-abused groups. And they again found some significant differences in bruising by body location, which on the next slide, I'll show you an image of what they found. They also found differences regarding pattern bruising. So they found that overall pattern bruising was a really uncommon finding, being present in only 8% of the total study population. But when they looked at abuse versus non-abuse patients, 38% of abused patients had pattern bruising, whereas less than 1% of the non-abused patients had pattern bruising. This slide shows the bruising by body location that they found. So this is a composite result of the bruising location that they had documented on all their patients. So I've got two of their tables here. So this one shows the front side of the body, and then this is showing the back side of the body. Just to orient you to these, the bottom row is non-abused patients, and the top row shows abused patients. They also have it stratified by age group. So you have your youngest age group on the left-hand column of both charts and your oldest age group over on the right-hand column. The colors, the color differences, so purple indicates bruising, pink indicates petechiae, green indicates that there was multiple or clustered bruising, and orange indicates patterned bruising. So when you look at this, I think this is a good visual representation of some of those differences that they found in body region. So when you look at the non-abused patients, in this youngest age category, there's not a lot of bruising. And when it is present, it's mostly over the shins and knees and the forehead part of the face. In the non-abused patients, as they get older, you see more bruising again below the knees, clustered over the forehead, maybe nasal bridge, chin, those bony prominences. And then again, some clustering over the back, specifically kind of the midline back, which is where your spinal prominences are going to be, and then elbows and backs of the forearms. So again, mostly bony prominences. Whereas if you come up here and look at the abused patients, so right away, when you look at the young age group compared to the non-abused, you can see there's way more bruising being seen. And then across the board, the locations are quite a bit different than the abused patients. You see bruising over the abdomen, the chest, soft parts of the upper thighs, posterior thighs, buttocks, increasing over the back. You also see the ears being involved, and then parts of the face that are different from the non-abused patients. So cheeks and eyes and neck are also involved. As I mentioned, they use their data to further refine and validate the previously proposed 10-4 bruising clinical decision rule. So they took this 10-4 rule and applied it to this study population to see how well it did in identifying abused subjects. So remember, the rule says kids with bruising to torso, ear, neck regions, or any bruising anywhere in a baby under 4 months is concerning for abuse. So when they applied it to this population, the rule correctly identified 331 of 410 abused patients. So I have some statistics up here regarding the performance of the rule. Just a quick review. Sensitivity refers to the ability of a test to correctly identify patients who have the disease, and specificity refers to the ability of the test to correctly identify people who don't have the disease, meaning it'll be negative if you really don't have the disease. In this case, the disease that we're interested in is abuse. So for a screening tool, we want high sensitivity because we want to capture all of those who might have the disease, but we also want to avoid too many false positives or screening positive for those that don't really have the disease. So in this case, the specificity was good, but the sensitivity wasn't quite high enough. When they applied this tool, 19% of their abused patients were still missed using that previously proposed clinical decision rule. So they felt it needed refinement. So they added some additional body regions that were identified with their new data, and then they modified the infant age threshold to actually include bruising anywhere in a child younger than 4.99 months. So essentially 5 months. And this is the final clinical decision rule that they came up with, termed 10-4 FACESp. So we'll go through each part of this and talk about what that means. So this tool, the 10-4 FACESp, the terminology is there to help remind you, what areas or what type of bruising is concerning for abuse. So we still have the 10 portion, torso, ear, and neck. 4, as a reminder, the tool applies to kids under 4 with bruising, but the 4 is also for bruising anywhere in an infant who's less than or equal to 4 months. I put an asterisk here because I want to point out one thing, that less than or equal to 4 months is not a hard and fast cutoff. So really what they're getting at there is kids who are pre-mobile. So this might include kids who are like 5 months, 6 months. So just keep that in mind. And then here's what they added. So they added some specific facial regions. So FACES stands for frenulum, angle of the jaw, cheek, specifically meaning the buccal or soft part of the cheek, eyelid, and then subconjunctiva, or the white parts of the eye. And then they added P in for patterned bruising. So you can use this rule if you're seeing a child who has bruising, who's younger than 4 years, and a positive response for any of these components would signal concern for abuse that may need further evaluation. When they applied this new and improved rule to their study population, the sensitivity was better, improved to 95%, with still a pretty high specificity of 87%. So it's a good screening tool. We'll go through in these next few slides just a few quick examples of bruising that would fall into these 10 for FACESp criteria. So remember, torso, this child has some clustered bruising on the chest and upper abdomen. Ear, this child has an ear bruise. And then this child's demonstrating some neck, petechiae, and bruising that you can see scattered around here. Or you can't see these babies' whole bodies, but these are meant to represent infants who are in that pre-mobile age category. And this infant has a cheek bruise and actually has some ear bruising that's cut off a bit here. And then this little baby has a chest bruise just medial to the nipple there. Faces, so frenulum, this baby has a frenulum tear under the tongue or sublingual. Remember to look at your frenulum under the lips as well. And then angle of the jaw, cheek, the soft part of the cheek in this child. This child has eyelid bruising, and then this demonstrates a subconjunctival hemorrhage. And then P, I just threw up a couple examples of patterns. This is a loop mark from a belt. This child, you can see some kind of long linear appearing bruise marks with sparing in between. That child was actually hit with a back scratcher. And then this one has that similar appearance of linear bruised marks with sparing, but they're a bit shorter. And this is more consistent with like fingers or hand slap. So I think we have time to, I have a couple just case examples where we can apply this 10 for FACES rule. So this case is a 5-week-old. He was presenting to a local ER for mouth bleeding and a sore under the tongue. The parents said dad was feeding the baby a bottle and just noticed some blood on the tip of the bottle. They deny any trauma. And the ER provider, when they call you, says, you know, the kiddo looks great now. There's no bleeding. But when I look in their mouth, there's this finding, and I'm worried it might be an injury or maybe it's an infection. I'm not exactly sure what it is. And so this is the finding. This is a frenulum tear. So if we apply our 10 for FACESp rule for this child, they have 2 components that are positive. They are under 4 months of age, and then they have a frenulum tear as their injury. So using that clinical decision rule, this would indicate that these injuries are concerning for abuse, and this child should have further evaluation, which luckily they did. They had a head CT that was normal, but their skeletal survey identified a classic metaphyseal lesion fracture along the distal femur. And then this was more subtle, but there was also a CML to the proximal tibia. And I have one other quick one. This was a 4-month-old seen for a well child checkup. This baby, during their checkup, the doctor noticed a bruise to the chest, and mom said, you know, I think maybe it's from like rubbing or pressure. Dad has a medical bracelet, and when he holds the baby, I think it, you know, probably puts pressure on its chest. And then the baby also had a bruise to their leg, kind of linear appearing bruise along here. And the mom said, well, you know, his legs get caught in his crib slot sometimes, so I think that's probably it. So in this case, the provider, you know, actually said these are pretty small. I think that could maybe make sense, but luckily called for some further advice. And again, when we apply 10 for FACESp, this baby has torso bruising. He is in the pre-mobile age group, and that is kind of linear, you know, could even maybe consider that pattern. So he, again, he has more than one positive on the 10 for FACESp. So we know this is concerning and recommended additional evaluation. So when he presented for further evaluation, he was also noticed to have clustered bruises to the back of his scalp, which were suggested to be from just turning his head in his own crib or maybe bumping it into his crib. And on skeletal survey, he had 4 healing rib fractures. This one's really subtle, but 4 healing rib fractures with callus noted. So I think to summarize both those examples I wanted to show, because they're common scenarios where small or isolated injuries and otherwise well-appearing kids might be overlooked or dismissed for being minor, or someone could assume an accidental cause or accept an explanation without exploring further. But without recognition and evaluation for a cold injury, young children with abusive injury could be missed and be at risk of ongoing harm. I think the importance, kind of take home importance of this tool is that it's the first validated clinical decision rule to help improve recognition of physical abuse in young children with bruising. And so I, encourage everyone to use this. It's a 10-4 FACESp is a useful clinical decision tool that can be applied really easily in the clinical setting and has demonstrated high sensitivity for detecting bruising concerning for abuse. And I think it can be really helpful for providers to use this to objectively evaluate bruising and recognize bruising that is concerning for abuse and that needs further evaluation. Important to keep in mind, it is a screening tool, so its use is to improve recognition of possibly abused children with bruising who need further evaluation, not a diagnostic tool. And a positive finding should prompt further evaluation for abuse, including potential medical evaluation or referral to CPS services. So that is everything I've got. I'm happy to go back and answer any questions. I think we have time for that and hopefully for some other cases.
Perfect. Thank you, Danielle. Does anybody have any questions?
Amy, Crystal Lloyd is asking, is there a printout available to post? Maybe that question's for Danielle.
I'm happy to share this like PowerPoint with you in a PDF form. And then I also, I think I shared with Deidre the two articles that I talked the most about in here, the two Pierce articles on this 10-4 FACESp bruising clinical decision rule, the older one, and then this updated one that hopefully can be kind of uploaded for sharing.
This is Susan in Joplin. I just had a quick question. I know I love the form that kind of shows high risk for abuse, areas that are in different colors. And I've kind of used that as, I know it's just a clinical decision tool, but I've also used it to communicate with my teams about why. And I just love it. I didn't know. Now I have to remember though, I can only use this in 4 and under.
This clinical decision, the clinical decision rule, the 10-4 FACESp, it's been validated in kids who are under 4. I would argue though that a lot of this is pretty broadly applicable even in older kids, right? Especially, I think you're referencing that little diagram where there's like the red areas that are concerning. Yeah, and those red areas correspond to these 10-4 FACESp areas. And so I think even though the clinical decision rule has been just validated in kids under 4, I think that information is still broadly applicable when you're thinking about concerning areas of bruising, even in kids that are a little bit older.
Well, I just used it the other day. I found it very helpful. I had some patterned ones that were actually on the side, but I said, look, these are patterns, so this concerns me. And I didn't have much history, so I had to just say, well, with the information given and the location of these and the research that we have on clinical decision making, this is why I feel that this child is being abused.
Yeah, and I think that's a good point about the history. Yeah, that's a good point about the history too, right? We always have to take these things into the context of the history that we're getting as well, to see, is there a history that could explain this bruise in a concerning location?
Thank you. That was great.
Susan, I always tell the story this is Emily, sorry, hi everyone. I always tell the story about like pattern and, location bruises and the importance of history, like Danielle was just saying. When my son was 3 or 4, he had this like rubber snake that he wrapped around like a door handle and pulled, and it snapped back into his chest. And he was like in a swimsuit or like not wearing a shirt, and he got a loop mark. And I like took a picture with the snakes next to it because you can actually see like it's the shape of a snake's head on his chest, but because of the way it snapped, it just like outlined the snake's body and head. And so he had a loop mark across his chest. And so he had a pattern bruise on his torso, and he was screaming, like it hurt. But he did it to himself. But I always just think it's a good example of, you do need the history, because even certain bruises in concerning locations with a pattern, sometimes occasionally can have that accidental explanation. But I think if you're not given a specific history, you are stuck exactly where you said that, like, given the location and the pattern and lack of explanation, the most likely thing is abuse. Yep.
So I feel like we hear a lot about kids getting extremities caught in crib slats and things like that, and that being the explanation for injuries. But just remember that crib slats are 2 3/4 inches apart. And this is a 4-month-old, and that was his lower extremity, not his thigh. And I will tell you, I used to have to unwedge my fat child's thigh from the crib slat. So, I mean, they can get stuck. But when they say like an arm got stuck, I mean, just remembering it's 2 3/4 inch, that's a fairly wide spot. So the lower extremity of a 4-month-old would be very unlikely to get caught in there.
Yeah, and I think I didn't share for that case, but I think that's a good example of why that, the bruising location should prompt delving into that a little bit more with that history for all the reasons that Amy said. But, when we asked a little bit more about it, mom was like, well, so she had actually just noticed the bruising when it was pointed out by the doctor. And so she actually hadn't seen his leg specifically caught in the crib and specifically causing the bruising. She just said, in the past, I've seen his leg kind of get wedged in there and couldn't really remember when. And when we said, in the past, did that ever leave bruising? Well, no, but I'm, just assuming it could maybe cause it.
I just had to throw in a little safe sleep knowledge. We've got to talk
Absolutely.
about sleep too.
I think there's a couple of comments too of I was just trying to read them while we were sitting here, but Dr. Moffitt said pattern bruising or bruising in uncommon areas for accidental bruising in a child of any age is concerning. So, the tool, I think, Mary, you can pipe in, but clarifying that, like, while the tool you can use, it's still concerning locations, and pattern is still concerning in older kids, not just kids under 4. I think that's what you were getting at, but feel free to jump in. And then Jim said the diagrams may be useful to offer to pediatricians and FPs to display in their offices to educate their staff and patients. I think that is a great idea. I don't know if anyone has had luck with kind of trying to roll out education to other pediatricians or other practitioners or family practice practitioners in their community about things. But we were just talking about that today with some of our pediatricians and practices in our community about ways to sort of roll out education about this stuff to them too. So I love that idea. And I don't know if other people have had success with other ideas and sort of spreading the knowledge in effective ways.
Well, I sure appreciate the background and the research that gives weight to our findings and our comments and our ability to protect these kids. It's helps a lot.
And just as a comment for Susan and Mary's point, so, and I can't remember the author, but I think it came out recently. There's a meta-analysis looking at bruising, and it looks at kids that are a little bit older. So if somebody else remembers that source, they can chime in. But from that analysis, they moved it up to age 6. So Mary Clyde's was just in her program, she only looked at kids under 4, so she can't really extrapolate necessarily. But in this other paper, it does include an older group and broadens that out a little bit. So that might be helpful.